I'm Simon Harrison, and on behalf of my co-authors, Keith Gray, Jamie Day and Tim Briggs, I'd like to introduce our paper which looks at the relationship between the volume of surgery carried out and the outcomes produced for nephrectomy and cystectomy for cancer. And we're using information from the UK Getting It Right First Time programme. So the relationship between the numbers of operations carried out in individual institutions and by individual surgeons and the outcomes produced has been of interest for at least 3 decades, with the thought being that surgeons and institutions that are carrying out higher volumes of surgery may be producing better results as a result of a practice makes perfect approach. Now, the NHS Cancer Plan, published in 2000 and backed up by the National Institute of Health and Care Excellence, improving outcomes guidance for urological cancer from 2002, has taken on board that concept and directed a level of centralisation of cancer surgery in urology in the UK, and that is now embedded. So what this paper really is hoping to do is to assess whether further centralisation into regional or super-regional centres would be of any potential benefit in terms of improving outcomes further. So we've used a methodology and data sources which hopefully address some of the limitations of previous studies that have looked at this question. We've used the hospital episode statistics and also information on mortality from national statistics to build up a database which contains 18,000 patients undergoing nephrectomy and 6,700 patients undergoing cystectomy between 2013 and 2018. And those operations were carried out in 124 institutions for nephrectomy and 67 for cystectomy. And we've subdivided for both operations into open, laparoscopic and robotic surgery. The approach that we've taken is to look at outcomes in terms of mortality, all-cause mortality within 180 days of surgery. We've looked at emergency readmissions within 90 days of discharge, and we've looked at lengths of stay as the measures of outcome and quality. Now, the confounding factors that we've taken on board using multi-level modelling are important and include age, gender, frailty and also year of surgery, because of course surgical techniques and performance alters as time goes by. When the raw data is looked at, there's an unexpected and counterintuitive finding that for nephrectomy, outcomes look to be better for smaller volume institutions and fewer operations per surgeon, whereas for cystectomy the converse applies. And that really illustrates why the multi-level modelling approach is needed to adjust for confounding factors. So when that modelling is undertaken, we effectively carry out multiple analyses looking at institutional and surgical volumes and testing those across the surgical procedures, both open, laparoscopic and robotic, and looking at the different outcomes, mortality, etc. And that produces 93 separate analyses looking at volume outcome relationships. There is no consistent finding of any association. There are, when we look at mortality, 2 out of the 31 analyses relating to mortality show a benefit for higher volumes surgeons, but 29 don't. For readmissions as an emergency, the 31 analyses all show no significant difference, whether it's higher volume or lower volumes. And for length of stay, there are 5 out of the 31 analyses which show a potential benefit for higher volume centres, but overall no consistent relationship. So what does this mean? What does the paper suggest? Well, firstly, I think that the recommendation made in the National Getting It Right First Time report for urology that complex cancer surgery should be carried out in centres that are performing more than 40 procedures a year per individual individual type of procedure, and by surgeons doing more than 20 a year, looks to be reasonable and appropriate. Because our data would suggest that in itself, further centralisation would not be a driver for improved outcomes. And that in turn means that any decisions about reconfiguration of services in the future should probably look at other issues such as, for example, ease of access to services for patients and cost effectiveness, and that may be based on procurement issues for expensive equipment. I think our experience also raises the issue that national data sources such as we have and which are ever improving are a really valuable resource, and we have the opportunity in the future to use these resources to identify units, be they larger or smaller, who are consistently producing excellent outcomes, and to look at the practices and protocols in those units to try and work out why they are delivering high performance. With the lessons learned from that, we can then disseminate that practice across the NHS and across the healthcare system, hopefully to drive up standards. Is this paper the last word on the volume-outcome relationship? Well, of course it isn't. It would be nice in the future to look at enhancing the modelling further, particularly, for example, looking at other confounding factors such as information about the tumours being operated on, so stage and grade. And it would also be nice to look at some more specific outcomes. So in colorectal surgery, you might look at anastomotic breakdown rates. For radical prostatectomy, you might look at continence rates. It remains for me to thank you for watching this video, and I hope you enjoy reading the paper and that it sets off some interesting thoughts.